Have you ever felt like you're flying on a plane, you're 40,000 feet in the air, and then you feel like the plane is having some turbulence? In that moment, you start thinking, what if this plane crashes, or fear sets in? And this is a common problem that we human beings start thinking about the negative things. When you have these fears, you think about the worst case scenario, and then you lose control of what you can do. If you hear the captain telling you, hi, ladies and gentlemen, we are going through a turbulence, you might feel even more anxious because that captain does seem what they're saying is you can trust that person. But what if the captain was confident and calm with a voice where the captain says, ladies and gentlemen, we're going through a bit of turbulence. I'd like you to please take your seat. So you see, the voice and how I'm speaking is going to make the passengers feel more calm. And the reason I'm sharing this story with you is because when you're actually consulting, you're that captain leading the interaction. And if you speak in a way that's going to create more uncertainty in the mind of the patient, you're going to cause more anxiety in your patient. So that's why it's really important that when you face uncertainty, you should not be afraid of uncertainty, especially when you get cases you haven't come across. So the more concerned we become over the things we can't control, the less we will do with the things we can control. That's a really important quote, and you might find it if you're reviewing your recordings. Notice what are the things that you might be doing, such as could be fidgeting your hands when you're not sure about something, or touching your face. These are small things that you won't really be aware of it unless you actually go back and review your recording and be like, okay, so when I'm not too sure this is these fidgets I need to work on. And that's where you might lose control of things that you can control. Sometimes people, they even shake as well, their hands. Stay calm and navigate through it so that you don't expose this anxiety or create a situation where it's going to worsen. And this will help you to prevent this knee-jerk reaction. So take a deep breath in and out and just carry on. Expect that there are things you might not know. Even if you don't have the answers, doesn't mean that you'll fail the station. And in fact, I've seen from GP trainees who didn't know anything about the case, but they still managed to pass it because they kept their cool. So we're going to cover three important elements today that you're going to learn. The first one is navigate uncertainty. Second one is elicit and readdress ICE. And the third one is shared management plan. How can you manage diagnostic uncertainty? Write in the chat, what do you think would be the best thing to do if, for example, you're not sure about something? So everybody seems to agree that, yeah, see, you need to communicate openly with your patient and you need to involve them in the decision making. So yes, having these moments where you're not sure about something, the worst thing you can do is pretend that you know or make things up. Because if the examiners find out, they're going to fail you. Whereas if you're transparent, if you're not sure about something, you're confident about what you're going to do to find out or how to reassure the patient, then you're more likely to do well. Diagnostic uncertainty is bread and butter in general practice. I'm sure in your own clinic, you will have patients who come in with various presentation and it doesn't fit a specific diagnosis. For example, let's say if you got a patient coming in with faint, it could be due to cardiac causes, neurological causes, or other causes, right? But that's part of the workup where you're taking a history to find out what's going on and try and find out what's the system involved. That's the first thing. And then you find out what are the symptoms and what are the red flags you want to ask, right? And by using these red flags, you're going to make a safe assessment. So please, when you get this diagnostic uncertainty, for example, let's say you've been asking various questions and trying to get a focus history, but still you don't have a diagnosis, don't feel like you're stuck, okay? Expect that there might be a station where there's no diagnosis, where you can't find a diagnosis. But you can still think about the differentials, what's most likely, and that will help you to assess what's a risk here. And I'll show you how to assess a risk. So a framework that I've taught many trainees is a clear framework. And this is going to help you make your life easier when it comes to diagnostic uncertainty. So CLEAR, first one, most important one is stay calm. Because the moment you get anxious and panic, you're going to lose control of the situation. So calm yourself first. Then there's a red flags, and we'll go into more detail in each of them. Okay. So the first thing is embrace uncertainty. If you find that there's a case you're not sure about something, it should not come in as something negative in your mind. It should be like, okay, that's my opportunity to shine. I'll stay calm and I'll navigate through it. All right. And remember what we talk about, the fidgeting, the body language. Make sure that you don't show any of these body language that suggests that you might not know what's going on or you're anxious. So the second thing is to look for red flags. When I say look for red flags, look for relevant red flags. You don't have to go over an exhaustive list of red flags because that's not really feasible in 12 minutes consultation. So if, for example, you've got a patient who is like a 18-year-old coming in with headache, the most likely differential in that situation would be meningitis, or it could be migraine. Whereas if you're consulting a 65-year-old man with headache, then your list of differential will be different. So you might be thinking giant cell arteritis. So your red flags would be different set of red flags. So you have to take a very targeted history so that you don't waste time asking things that's not really relevant. Is this clear so far? Yeah. So the next thing is to explain to your patient. So you can explain to your patient the theory or hypothesis that you've got. All right. So patients come in with some symptoms, but for example, let's say you're not sure what's going on, but at least you need to put a hypothesis forward based on your assessment, having taken a focused history. All right. So for example, let's say they're coming in with a skin condition and you've asked all the red flags. You can't see anything that is serious going on. They don't have any weight loss. It's a rash that looks like it's not serious. So then you explain to the patient and then you acknowledge. For example, you might say, I'm not exactly sure what causes rash, but the good news is it doesn't look like anything serious. So we're moving forward even if we don't know the answer, because we're actually successfully ruling out these differentials. And then the next part is reassure the patient. So you can reassure the patient, and that way the patient will have less uncertainty. All right? Is this clear so far? Any questions? So when it comes to reassuring the patient, you need to practice this, because if you don't practice this, then it might come as if you're not sure what you're saying or it's not coming really naturally. So for example, you reassure the patient, you might say, we might not have all the answers yet, but we'll take the next step. So I think the best thing would be to arrange investigations to rule out X, Y, or Z. Or you might say, we'll take this one step at a time, and I'm here to support you throughout. So at least the patient feel like they are not abandoned in this. And then the next thing would be setting the right expectation. So for example, you can say to the patient, let's review things in a week. And if there's no improvement, we'll explore the next step together. And remember, if you're not clear about the diagnosis, make sure that you safety net appropriately. So tell them what are the symptoms to look out for and what do they need to do if, for example, they're having this symptom to get in touch back with you. So whenever you have uncertainty, you can use risk management to make a safe management plan. So when it comes to risk, these are things such as possibility of harm or suffering, potential outcome that are not known, or probabilities of occurrence where you can measure it. So whether it's a low risk, medium risk, or high risk, right? So why do we manage risk? For patient safety, for ethical responsibility that we've got as a doctor, and to make an informed decision. Let's go over this example. 75-year-old man with chronic atrial fibrillation is on anticoagulant therapy. Which one of the following factors poses the highest risk of major bleeding? Hemoglobin less than 13 grams per deciliter is the highest risk factor here. So if you look at the points that you actually give based on these factors, you will see that this is the one. And let's say you have found that there's that risk in this patient. So then you need to make the next step, as in how do you manage this risk? So if this patient indeed has a hemoglobin that's 12 grams per deciliter, then it's going to be a high risk. So you need to make an intervention. Could be a referral, or it could be you need to do some urgent blood tests to repeat it. So as you can see, once you've actually assessed the risk, then you need to think about whether it's low risk, medium risk, or high risk. If it's a low risk, then you monitor and reassure the patient. If it's a medium risk, maybe there is a need for investigation or referral. And if it's high risk, then the next step would be to make an intervention, right? So even though you don't have a diagnosis, you can still do that very well. So the next thing I'd like to talk about is ideas, concern, expectation. But before we talk about that, what made you choose the one-to-one?
It was based on feedback from my friend Mustafa. He is someone I respect his opinion a lot. One, he is knowledgeable, but when he told me initially that his exam didn't go well, I was surprised how. And if he could recommend that I do this course, and his reasoning was like, Jonathan, I just did this course with Erwin, and I tell you that's the best thing you'll do for yourself. I want you to pass your exam in first sitting. And if you start doing this course, I'm sure you're going to do that. And I think I really benefited from, what I spent for the course, not just for the exam, to be honest, for my real life practice. I am a better, my consultations are better now, even with real life practice than just before. I don't really care about your agenda or your eyes. I just want to finish. And the truth is that if you're trying to save time, if you address patients at their concern and expectation and properly give therapy, even in real life, you save more time doing that than going round and around trying to bring up what's a nice guideline that patient is not really interested in. So I chose this course because there are good feedback from colleagues who have done, and like now I'm here to also testify that it's the real deal. And thank you so much. I really, really appreciate all your efforts, because it was real. It was dedication. It was not just this is a course, this is what I have to do. You brought in passion to teach people who are in your course, and that's really well appreciated. So thank you.